So as it shows, I'm a professor of medicine at Rush University. As you can tell, I've been there about 35 years. So pretty long lived for an academic institution. We tend to move around a lot. So let me get into a little bit. I'm the first speaker, so I'll get a little into the pathophysiology, but I don't want to get deeply into that. I'm not a rheumatologist, so I'll focus on how that affects the GI tract. But the reason I want to give this as a bit of an introduction is that the new data, the new interest in scleroderma in the gut happens to do with dysbiosis, which is an abnormality in your colonic microbiota, and whether early life exposures are leading to changes in that microbiota that down the road can lead to autoimmune conditions, including scleroderma. So it's a theory, I'll delve into a little bit, but in order to get to that theory, I just want to go through the background of the disease real quick. So basically, as you know, there are blood vessel abnormalities that are autoimmune in origin that then lead to local areas of loss of organ function, loss of organ oxygen. So these areas get scarred from damage from low blood flow. That leads to an abnormal repair process through there's inflammation. As a result of inflammation, there's generation of new tissue and fibrin or scar. And if that process is sort of off kilter a bit, and then you can end up with abnormal repair and scarring. And then that scarring then leads to abnormalities in the motility of the gut that affect things like absorption, secretion, the reflux disease that we see, constipation, etc. So that kind of scarring and tissue replacement is the root of all evil when it comes to the GI tract, because that gets, that tube, or basically a big donut, and the entire tube has to move and move on time and move properly. And when that gets damaged, we have trouble. So GI tract function is pretty straightforward. You chew up your food, swallow it. Remember, we'll talk a little bit about the oral cavity issues with regard to scleroderma. The esophagus, we'll spend a fair amount of time on the esophagus because that is the area probably most concerned to patients. Both ends of the spectrum, the colon misbehaves and the esophagus behaves. We get into trouble in both those areas. I don't have much gastroparesis or slow stomach emptying in my scleroderma patients. It pops up once in a while, but it's nowhere as severe as I see in my patients who have things like end-stage diabetes, etc. Small bowel motility can be an issue. If you look at the organs in the GI tract, they break down in what I call transit organs and storage organs. Your esophagus is a transit organ. It just wants to move things through there as quickly as possible. You should spend maybe 2, 3, 4, 5, 10 seconds at most in the esophagus and be dumped into your stomach. Your stomach is a storage organ. It hangs on to your food for several hours after you eat it. The top part of your stomach has to expand to accommodate that load of food. That adaptive relaxation has to occur to allow the stomach to properly grind up the food in the bottom part of the stomach. So the bottom part of the stomach is like a mix master. It grinds things up, makes it as tiny as possible, and squirts it out into the small bowel. Small bowel does not like big particles. It likes things small and sort of pre-ground up for it. It then enters the small bowel. As you can see here, in the upper small bowel, the jejunum is where, let me get my laser here. I think that's it. No? Anyway, which one is the laser? You're not working for me. Anyway, the upper small bowel, the jejunum, is where the majority of absorption and secretion occur. Ileum is not, that's the bottom part of the small bowel, isn't as involved in the processing and absorption of nutrients and reabsorption of fluid. It's really important for bile salts and B12 though. So when the ileum, the low end of the small bowel, is not working, you'll see specific deficits in perhaps bile salt reabsorption. That can lead to diarrhea when the bile salts hit the colon. And then most importantly, B12. We store a lot of B12. It's hard to become B12 deficient in the United States, but it's possible. And then the colon. Colon's a storage organ. Small bowel transit, colon storage. Colon storage, 55 hours is about normal. Anything above 55 hours of poop sitting in your colon we consider abnormal. When I was able to do these kind of cool studies on colonic motility, which the insurance companies won't let me do anymore, they were kind of interesting. I had some patients who had colonic transit times that exceeded 155 hours. So obviously, that can become a little bit uncomfortable. Some of my scleroderma patients were in that, 80, 90 hour transit rate time. So we were always working on trying to get that moving a little bit too. Because we're big donuts, right? If you hang up things anywhere else, it affects upstream, right? So if you block the rectum, you can be vomiting from rectal occlusion. So we have to pay attention to the patency of the entire GI tract. We need the entire GI tract to be moving to feel healthy with our bowels. So we spend a lot of time working on motility in our scleroderma patients. So as I mentioned, if you have scleroderma, you're probably fighting with some kind of GI issue. Mostly I'd say the esophagus, probably constipation number 2. And my least favorite thing for patients, because it has the biggest effect on quality of life, are anal sphincter problems with anal sphincter incompetence. But it can affect any part of the GI tract, oral cavity, basically to the anus, and it can be slow or rapidly progressive. I would say it's mostly slowly progressive, but occasionally, as in my one gentleman in the hospital right now, it's a little bit rapidly progressive for him. Old or young, doesn't matter. When you get the disease, we can see GI tract issues and everything. So there's various grades to damage. The blood vessel is the first, or grade 0 injury. Grade 1 injuries when the loss of blood flow damages the nerves, so now they're not signaling properly. Basically the nerves of the gut wall are kind of the shepherds that move the sheep, or sheepdogs that move the sheep along. So your myocytes, your muscles in the small bowel are the sheep. They just listen to commands from above. So you have basically the sheepdog, that's the intrinsic nervous system in the gut. It kind of tells them when to move, but the sheepdog gets its commands from above, and that's going to be your shepherd up there in the central nervous system. Central nervous system's intact. It's mostly local problems. It's a problem maybe communications between these cells, the sheepdogs, if you will, who move the sheep along, or damage to the sheep. If the sheep are injured, can't move, then you're going to have a problem. And you see problems with both those. You see muscle injury and you see nerve injury, which all basically get that way because they need blood flow in order to stay healthy. Your nerves are very metabolically active, require a lot of blood flow. Obviously, muscles require a ton of blood flow, particularly at the end of meals. If they're not getting it, they're not happy. What happens is there's muscular injury, and when that muscle gets injured, you get scarring and fibrosis. And that scarring then causes dropout of the myocytes or the muscle cells in the small bowel, colon, esophageal wall. And no matter what the sheepdogs are telling the sheep to do, if they aren't there, they're gone, they're damaged, it's not going to move. And that's our main issue, is movement. So a little bit on that theory I was telling you about, dysbiosis. I think I find this kind of intriguing. This is fairly new. The idea is that if you ever heard the term, there's a phrase I got, I can't remember where I got it, I think it was a microbiologist, but he used the term that your DNA basically your genetics, your DNA basically loads the gun, and the environment pulls the trigger. So you're loaded with your DNA, and that you can't tell you about. Mom and Dad gave you that. If you have certain DNA predilections to certain diseases, Scleroderma, Crohn's disease, ulcerative colitis, colon cancer, that's sitting with you. There's nothing you can do about that. Don't get me wrong, there's certainly people are tinkering around with things to try and change our genetics a little bit, a little scary, but a concept. Mostly we try to work on the environment. So if you're in the environment in which you come across a certain trigger, you have the right genetic predilection, you load the gun, you pull the trigger. Genetics, environment, the two together work against you a little bit. The focus on the dysbiosis is the environment. Are the early environmental insults that we get as kids that might put us at higher risk of downstream autoimmune disorders, inflammatory bowel disease, etc. Your gut microbiota is insanely important to your well-being and health. I think, when I was a kid in the 50s and 60s, man, they threw antibiotics at us like crazy. You sniffled twice, you got an antibiotic. I had a little pink eye, viral infection. I got an antibiotic. I got antibiotics all over the place. My mom loved antibiotics. And that's a little bit of an issue. Those bacteria are there for a reason, particularly in the colon. They don't like seeing antibiotics. They protect us from problematic organisms, Clostridium difficile. They lead to immune tolerance. So if you start switching your microbiota, you may have an immune system that gets a little intolerant of what it's seen in the colon. Basically, the microbiota you got from your mom, not your dad. It supposed to reflects your mother's microbiota print. And we can do fingerprints of people's microbiota now. And what we do is we can compare them to the general population. So they have looked at Scleroderma patients. And what does your microbiota look like versus the general populations? And there are differences. Again, these are our friends. A lot of the push on probiotics now is the idea that, our microbiota a good thing, so more of a good thing is always better. I'll give you a little bit of the downside of that in a minute. I don't think probiotics are necessarily the answer quite yet, and we use that term very generically. You go to Whole Foods, you buy a probiotic. You're not buying a specific organism necessarily. When your healthcare provider tells you get a probiotic, they're not going to tell you to get necessarily bifidobacterium or to get lactobacillus. We don't have that kind of granular data yet on this. So unfortunately, the information we have scientifically on prebiotics and probiotics is not as clean as it should be. But your colon has trillions of organisms. If you lay them end to end, they go around the world a couple of times, I believe is the number. They have a huge impact on health. There's a lot of focus on three areas with regard to your microbiota. One is autoimmune disorders, Scleroderma. Number two is sort of allergic disorders and your tolerance to certain allergens in the environment. And number three are inflammatory disorders. Another group is sneaking in there too, and that is the neurologic disorders like Parkinson's and Alzheimer's. But these have been the main focus of what dysbiotic microbiota do to us. and put us at risk for. So dysbiosis is an altered colonic microbiota from what might be considered the norm. So if we look at a normal population, we take the fingerprint of their colon and we compare a patient with a disorder, diabetes, scleroderma, obesity even, and we compare the two. Do we see certain populations of bacteria shift in that group? One of the very interesting things is when we have these patients who get Clostridioides difficile infections, we've been doing fecal microbiota transplant. So we get fecal material from a pool that has been checked for every organism that's problematic or pathologic organism out there. We then instill it during colonoscopy to get rid of the Clostridioides difficile. One of the interesting concerns about that, though, and the reason that they find the healthiest, thinnest people they can to get to donate stool is there's a concern that you could actually transmit the risk for obesity when you do a fecal microbiota transplant. You could transplant the risk of scleroderma, or you could transplant the risk of diabetes if you give a fecal microbiota transplant. So there's a lot of push to do FMT. We're a little bit hesitant about it. You have to make sure you have the right population of people to do that. But there is some concern that we start messing around with this microbiome, we might get ourselves in a bit of trouble. But we know that dysbiotic microbiota can lead to problems, particularly in the lung and skin. And of course, these are areas of concern in systemic sclerosis or scleroderma. So there is data on scleroderma patients and their dysbiosis. And so when you look at a patient with scleroderma, you will find increased levels of bifidobacterium, Prevotella, Lactobacillus, Fusobacterium, and Gamma proteobacteria. What does that mean? Is that a cause and effect? Is it because of the presence of the bacteria that you've gone on to develop certain symptoms or scleroderma itself? Or these are a reflection of the slow motility in the gut? We don't know if there's a cause and effect analysis. There's decreased levels of Clostridium and fecal bacterium. So the question again, if we see people, you need to do studies longitudinally. I need to see people in their childhood and see if these issues are present then, and then later in adulthood they develop scleroderma. Right now, just grabbing an individual out of the population and looking at their point prevalence of a certain bacteria is a difficult way to make a cause and effect analysis. So that's what we don't know. Is this a reflection of scleroderma? Is this a cause of scleroderma? That's the question we don't know yet. We do know that scleroderma patients are different from the rest of the population because of these organisms. It is unique, and it may have consequences either in the development of SSC, or it may have consequences in the type of SSC or the type of symptoms you get. Some of these bugs enhance the inflammatory response, and the inflammatory response, as you know, leads to fibrosis and scarring, which is an issue in the gut, obviously. But some calm the immune system and set back the inflammatory process. They make you more immune tolerant, which is obviously a good thing in some with autoimmune disorders. Some are invasive and not friendly, like a probiotic would be. These are called pathobionts. So you think if there's an issue of the wrong kind of bacteria, why don't we overwhelm them with the good guys, give a bunch of probiotics, shouldn't they help? Well, if we look at those names again, when you go over to Whole Foods, you'll see that where we see increased levels of certain bacteria in the gut, those are the ones you see a lot at Whole Foods, or any old, you go to Walgreens, you buy any kind of probiotic, you'll see a lot of bifidobacterium and lactobacillus in there. So, should we be taking a lot of probiotics? I don't know. The data is just not too good there. They seem benign, and there's a lot of push online to go ahead and take your probiotics. But I wish I had more granular data to tell you, okay, so avoid ones that, let's say, contain lactobacillus and bifidobacterium if you have lactobacillus, because you already got too much of those guys anyway. Why don't we shift you over to Saccharomyces or something? I just don't have that data yet. But I put this out here because this is an area of research focus as far as the etiology and the treatment of scleroderma, that you'll have a lot more information, I think, coming down the road, probably within the next couple of years. So be a little careful about the probiotics. I don't think it's contraindicated. Again, I've not seen any data suggest that they worsen the symptoms in patients with scleroderma, but they're not a panacea. I don't think they answer all our questions, and you always have to be a little bit worried about them. Satish Rao at University of Georgia published a study it's controversial, about maybe 4 or 5 years ago, in which he found that patients taking huge amounts of probiotics who have slow gut motility, scleroderma patients, what happens is they build up lactic acid in their bloodstream because of the metabolism and the fermentation going on in the small bowel with all those extra probiotics. And that can give you a little brain fog. You might feel a little out of it. So again, if you've started taking a probiotic, you don't feel quite yourself, a week or so down the road, it may be that you're overdoing it a bit. You want to back those doses down. If you've noticed that at all and you're on a probiotic, maybe stop it for a couple of weeks and see if that sort of brain fog gets a little bit better. Again, controversial article, but it makes some sense on a physiologic basis. So how did that microbiota get sort of messed up in the first place? So that's where it even gets more intriguing. It's, again, remember we were talking about early life exposures. Some of the questions is that, at least in animal studies of scleroderma-like syndromes, early exposure of young animals to antibiotics increase the risk of this process later in life. So there's animal data suggests that, if mom, like my mom, is pumping you full of antibiotics early in life, sort of playing with your colonic microbiome a little too much, that can get you into trouble. There's definitely data that a single exposure in infancy to antibiotics can increase the risk of allergy syndromes downstream. So we are becoming extremely aggressive about not using antibiotics if we don't have to. Most of our troubles are viral. Most of your diarrheas and such, your colds and pink eye, et cetera, are viral. They don't respond to antibiotics anyway. You don't need them. So antibiotics are it's like a savings account. You have your antibiotics are going to work for you so many times, and they're going to conk out because you're going to develop resistance. So every time you use them, you're making a withdrawal from that, from that savings account of your antibiotics. Ones are going to work for you. So you want to be very careful about that. Unfortunately, when you go to a lot of urgent care centers and stuff, it's sort of they sort of want to appease you and give you an antibiotic, get you out the door. So be careful about antibiotics. Certainly, they're reasonable in certain situations. They obviously save a lot of lives. They're used all the time. I get it. Early child exposures probably have a detrimental effect in the colon in some people, particularly if you have the right genetic predilection down the road. So again, judicious, careful stewardship use of antibiotics is the key to avoiding downstream issues with it. Other risk factors, Helicobacter pylori, there's conflicting data whether that infection in the stomach increases the risk or decreases the risk of scleroderma. There was a study suggesting there was a higher risk in patients with scleroderma, but follow-up studies have not been able to support that. But you might hear that noise on the internet a little bit about whether Helicobacter infections play a role. I do know this, that we certainly, I'm not a big fan of trying to get rid of H. pylori in my scleroderma patients because H. pylori has a little side benefit. It kind of reduces acid suppression. So we do notice that patients who have their Helicobacter eradicated have a higher risk of acid reflux, and the consequence of that, called Barrett's esophagus, which is a change in the lining of the esophagus to the small bowel that has a slight precancer risk with it. So I'm not a big fan. I don't check for it specifically. Unless my patients with scleroderma have an ulcer in the stomach, I don't check for it. I don't want to know about it. Don't ask, don't tell. If I find Helicobacter, I'm kind of stuck treating it. I'd rather not know about it, so I don't go checking for it. Smoking data is really weak in scleroderma as to whether it plays a role, but obviously it impacts other GI disorders, particularly gastroesophageal reflux disease. So I really work on my scleroderma patients not to smoke. It just makes sense. So on to GI symptoms, we'll dig into here a little bit. So the 98.9% of patients with scleroderma will have one or more of these GI symptoms. Meliorism, which is a term I think they use in England, I'm not particularly familiar with it, but it's bloating or abdominal distension, heartburn, trouble swallowing, constipation, diarrhea, malabsorption, and its consequence, which is weight loss. So a lot of my patients with scleroderma have weight loss. Most of the patients I have with weight loss are having difficulties either with swallowing because of the esophagus, or more importantly, they have malabsorption from bacterial overgrowth, and we'll talk about that syndrome in a little bit here. Nausea, vomiting, mostly a lot of that's regurgitation, not true vomiting, but some of it's vomiting from gastroparesis, gastro, stomach, paresis, slowness. Bleeding, which we'll talk about. I just, this week, Saturday, Sunday, Monday, Tuesday, was Digestive Diseases Week in Chicago. Terrible sounding week. But I was in the hotel one time, and a patient saw Digestive Diseases Week on the wall, and she said, that was my trip to Cancun. But yeah, so we had Digestive Diseases Week, and I always look through it to see what's new in scleroderma, what abstracts. There was one abstract on scleroderma, just one, and it had to do with bleeding and the angiectasias, basically pointing out that the most common group of patients who have bleeding from angiectasias are patients with scleroderma, but there wasn't a lot out there, unfortunately. I was hoping to see more data on the promotility drugs, which are kind of new, and then dry mouth. So, the consequences of GI injury are going to be malabsorption, maldigestion, and malnutrition, obviously. Intestinal suit obstruction, which I mentioned, that's the main reason I have patients in the hospital with scleroderma for intestinal suit obstruction. Ogilvie syndrome is kind of the colonic version of an intestinal suit obstruction. The colon becomes very dilated and won't empty. And then depression over the GI complaints, which can be very life-bothering and affect the quality of life very significantly. So on to the areas I'll cover: oral cavity, esophagus, stomach, small intestine, colon, rectum, amus, and even a little bit on the liver and bile ducts, although that's not a predominant problem. So oral cavity, basically a lot of manifestations. I don't deal with them too much, basically because I mostly have my... So I have a lot. We're very multidisciplinary. I have docs who help me with the ENT side of things. I have my colorectal surgeons who help me out with the anorectal issues. I have interventional folks who help me out with any kind of biliary strictures and such that might happen, although those are rare. I have my chest surgeons who help me out when I have patients with severe reflux disease who need surgery. I have my fellow neurogastroenterologists, Dr. Abraham and Dr. Robinson, who do some of the motility studies. And I'll talk to you about a very new kind of exciting type of way of assessing esophageal motility called FLIP in a little bit here. But dry mouth, reduced mouth opening, dilated blood vessels or telangiectasias can occur in the mouth. They can occur any part of the GI tract and can lead to some oral cavity bleeding, although typically not severe. There can be issues of, as I mentioned, come over there, look at Raynaud's phenomena, so you can see the discoloration in the mouth and mostly around the lips, and then you can have that tingling sensation. So a lot of oral cavity issues. Again, most of these are handled by our ENT docs who help me out with this a little bit. They're mouthwashes and such for dry mouth and things. As far as the oral cavity bleeding, usually my ENT docs do the laryngoscopies to control angioectasias in the mouth and do a pretty good job of that. Now, on to where I spend most of my time is in the esophagus with swallowing of food. Obviously, your esophagus is a very short but very important longitudinal tube that has both circular muscle and long muscle. And what the circular muscle does is it pushes that bolus down. The longitudinal muscle sort of opens up the pathway and shortens the esophagus to make it easy to get in there. And you have a little valve at the bottom, the lower esophageal sphincter. Very important in maintaining a barrier between stomach contents and the esophagus. And the problem with scleroderma is the muscles in that lower third of the esophagus have lost their sort of oomph a little bit. The pump function of the esophagus is damaged. So because the muscles don't squeeze well, the esophagus doesn't clear those reflux events well. And the lower esophageal sphincter at the bottom is too relaxed. If you're average reflux patients who have heartburn, the valve relaxes inappropriately, something called a transient lower esophageal sphincter relaxation. In scleroderma patients, it just stays open. It's just a common channel between your stomach and your esophagus. And then on top of that, the esophagus isn't pumping strong enough to push that material back down into the stomach. Problem is we don't have great drugs to increase esophageal motility. We have lousy drugs to increase esophageal motility. I may have been on metoclopramide, one of my least favorite drugs in the world. It helps a little bit, but not enough that our current guidelines recommend it. It has a ton of side effects, pretty serious ones, I might add, so I don't use that drug much. There is a Canadian version of it called domperidone that doesn't have quite the central nervous system side effects, but still has the cardiac side effects. For the extra bang you get over taking a proton pump inhibitor drug like Nexium or Prilosec, it's just not worth the price of admission. So what we do, because we don't have a drug to fix the problem directly, is we do an end around. We take away your acid. There's an old joke, you can't go see a gastroenterologist and leave the office with your acid. We're going to take it away from you. We do that all the time. Lately, I'd say maybe within the last 5 or 6 years, there's been great concern about taking people's acid away from them. That it may lead to, I've seen all sorts of things, from Alzheimer's to gastric cancer to bone density loss, et cetera, et cetera. Most of those have not panned out as true cause and effect analysis. They've been associations, not cause and effect. I'll show you a little bit of how we got there. I think the one that was probably the earliest to come down the pike was the bone density issue and the increased risk of hip fractures, particularly in women taking drugs like Prilosec and Nexium for their heartburn. The studies were done. They look at patients not on Nexium, let's say, look at patients on Nexium, and they found more hip fractures in the Nexium taking patients. The problem is that whenever you look at the associations like that's a very easy study to do. You just take a population X, population Y, and look for a variable. What's hard to do is to show that variable is causing that disorder. And that's the problem with the osteoporosis data. When they went back and looked at it in what we call a cause and effect analysis, and they drilled down into the data a bit, they found that, guess what? Women who take medications for osteoporosis get heartburn because those medications damage the esophagus. So guess what they do? They go to Walgreens, they buy Nexium. So when you look at them, you say, oh, look, all this Nexium they're taking, they're getting hip fractures. Well, they're taking hip fractures, so they're on these drugs that cause heartburn and damage to the esophagus, so they went to the grocery store and got Nexium. So when you factored that out, the risk disappeared. So again, the only time we see that kind of osteoporosis and a lot of these issues is when the doses are very high. The issue in Alzheimer's has not panned out in cause-effect analysis. The only thing the FDA currently recommends if you're taking long-term PPI medication is you watch your kidney function. There's a rare condition you see with a lot of drugs called interstitial nephritis. It's kind of like an allergic action in the kidneys. We keep an eye on that by checking what are called the BUN and creatinine. These are kidney function tests once a year. And the other weird one is magnesium levels. For some strange reason, genetically, some people may lose a little extra magnesium in the urine when you're on a proton pump inhibitor. So once a year when you're getting your kidney function test, we ask the docs to check a magnesium level. If it's low, we give you magnesium. If it's high, great, stay with it. It's very rare. I think 1 in about 1,000 patients or less will develop that kind of hypomagnesemia. But be wary of it. You're taking a proton pump inhibitor with a lot of scleroderma patients are appropriately doing that. Just if you get a little weakness, start noticing muscle cramps, get your magnesium level checked. Might be an issue for you. We go after the acid big time because of all of my patients who have acid reflux, my scleroderma patients have the most damage. They have the highest risk of Barrett's esophagus. That stricture, which you can see at the arrow there, that's literally almost a pinhole that gentleman was trying to eat through. I was absolutely amazed that he went that long before we got into that. We got that stretched open and opened up for him. But the key thing there is that those will come back. 80% of your strictures will come back if you don't take an acid suppressant. If you have Barrett's esophagus because your esophagus is reacting to the acid by changing to the lining of the intestine, if you don't take an acid suppressant, that's going to progress, and there's an increased risk of esophageal cancer there. So that protects you from esophageal cancer. It protects you from oral cavity damage. It protects you from laryngeal injury. It protects you from pulmonary fibrosis. The last thing in scleroderma is lung injury. So I get annoyed. I get really annoyed when my primary care docs tell me, oh, it's too dangerous. I can't be taking all this Nexium. No, I mean, the consequences of not taking it, everything's a risk and benefit ratio, right? There's a risk and there's a benefit to something. The risk to taking a PPI is way down here. The benefit is huge, and particularly in a scleroderma patient. The benefits are huge. And again, some of these risks have been greatly overstated in the literature. I mean, obviously, your CBS News, you're going to scare people. You say, stay tuned, your PPI may be trying to kill you. You're going to stay tuned, right? If you say 2 years later, they go, hey, we were wrong, it's not trying to kill you, you're not going to stay tuned. You're going to move on to something else because CBS told you that wasn't true. So, be careful about it. There's a lot of, they like these kind of stories that terrify you about the meds you're taking, and you have to be careful. There's a benefit. There's a we forget that benefit sometimes, and the benefit of a PPI in my scleroderma patients is gigantic. Avoid strictures, avoid heartburn. I mean, just if you've ever had heartburn, if you have that acid get up into the oral cavity, I've had that happen before. That is an incredibly annoying and uncomfortable experience to have that chemical burn in your esophagus. That acid is a pH of 1. That's as nasty as it gets. And you make 2 liters of it a day, and you don't want it in your esophagus dwelling in there, burning the esophageal surface and causing strictures and esophagitis. So I'm going to jump past here a little bit. The other thing about, it's not just heartburn, right? Some of you may have cough. You may have chronic throat clearing, sore throats, burning tongue, tooth enamel loss, recurrent sinusitis. These are all these extra esophageal manifestations of reflux disease, chronic chest pain, regurgitation. It's disturbed sleep. Patients are just really floating up at night, and they're getting burning and waking up in the middle of the night and getting terrible sleep. By the way, the little thing about sleep, if you have reflux, you haven't figured this out, don't eat within 3 hours of going to bed, sleep on your left side. Most of the patients I have reflux have figured that out on their own. I don't have to tell them that. But if you sleep on your left side, the stomach's like a sump. It's down here. It has a hard time getting up into the esophagus. Sleep on your right side, it's up here. Real easy track into the esophagus. Excess belching, hoarseness, dysphonia, loss of voice. So there's a lot of reasons to treat reflux aggressively. We'll talk about treatments in a little bit here, but PPIs are the cornerstone of that. Stomach disorders, gastroparesis. Luckily, I don't see that much. It's poor stomach emptying due to, again, neurologic damage or muscular damage in the stomach, leads to pooling of material in the stomach. This really worsens the regurgitation, right? Because if the stomach is sitting there full of material, there's a lot to come up. So some patients I have who have very refractory reflux disease to acid suppressive therapy, we'll evaluate them for poor stomach emptying and have to work on that. Now, when there's issues of poor stomach emptying, then we do have to try to use promotility agents, of which, again, metoclopramide is one of them, which, again, not my favorite drug, but used in modest doses is pretty safe. I'll talk to you about a new drug called Motegrity or prucalopride that just came out a couple of years ago that has a nice prokinetic effect through the entire gut, not just the esophagus, stomach, small bowel, and its claim to fame is constipation in the colon. We've been using that more and more in global gut GI disorders and motility issues. Usually takes a little bit of fussing with the insurance companies because they don't like paying for it. It's more expensive than some of the standards like Miralax and linaclotide like Linzess and such. But we push for it hard in our patients who have these global dysmotility disorders because it has a unique promotility effect on the small bowel and the stomach. as well as the colon. The food doesn't accommodate, just sits there. That's gastroparesis. It's an abnormal sort of messaging between the neurologic system in the stomach and the muscles. There are blood vessel abnormalities called GAVE in the stomach. I think I have a picture here. Yeah, so this is GAVE. It used to be called watermelon stomach. These linear red stripes look like watermelon in the stomach. These are engorged blood vessels. The source of these isn't quite clear. It may be that there's vascular damage, and the body, in an attempt to repair vascular damage, the scleroderma releases hormones and compounds that stimulate vascular growth. And so you get these ectatic or enlarged blood vessels, which can really bleed if they get their mind to it. So we have a cool little toy called an argon plasma coagulator. It's like a little paintbrush we use, and we just sort of paint it with a charged gas called plasma, and that basically cauterizes these. They tend to recur, so we may need to do it once a year, maybe twice a year to cauterize these things, but it's very effective treatment. This is one, as extensive as GAVE can be, or gastric antrovascular ectasia, is probably one of the easier vascular malformations of the gut to treat. It's very accessible and very easy to get a hold of endoscopically. So small intestine, slow transit in up to 88%, 90% of patients with scleroderma, but it can be as low as 40% in some trials. About half, a little over half of patients will have symptoms related to small bowel motility disorders. That can be bloating, can be nausea and vomiting. Most importantly, it can be malabsorption and maldigestion related to small intestinal bacterial overgrowth, which I'll talk about. So in my clinic, most of my patients with weight loss are dealing with malabsorption, and most of it's due to bacterial overgrowth in the low end of the small bowel. That's the key thing. The other issues are going to be pseudo-obstruction, which we talked about. Pseudo, false obstruction. So the whole small bowel just stops moving, gets very dilated. Everybody's running to the bedside, ready to operate, take out whatever's blocking the bowel, but you won't find anything. The last thing somebody with pseudo-obstruction needs is anybody's surgical hands in there. Pneumatosis, cystoides intestinalis. When you have stasis of bacteria in the small bowel, what can happen through the process of fermentation is the gases can change, and they can cause little blebs in the wall of the small bowel. They can look very disconcerting. You see them on an x-ray. It looks like a perforation of the bowel. Kind of interesting. They respond to antibiotics, but also responds to changing the gas you take in. So if we can get rid of nitrogen and switch it for oxygen, the blebs decrease in size. So one of the things we do with patients who have this pneumatosis, cystoides intestinalis, come to the hospital, we put you on high-flow oxygen. That washes the nitrogen out of those cysts, and the oxygen will get absorbed and they go away, which is kind of nice. But antibiotics help too by reducing the amount of bacteria in the small bowel that are fermenting and creating all those gases. And then there's just these odd jejunal diverticulites, little potholes in the wall of the jejunum. Why are they important? That's the upper part of the small bowel. They're areas of stasis. And when you have, remember, talk about the small bowel as a transit organ. Everything's moving through there pretty fast. I told you about 55-hour transit rate in the colon, small bowel transit rate, 2 to 6 hours max. You should scoot right on through there. And that's 22 feet, 25 feet. Yeah, it's huge. So it's really moving along. Colon's only about 3 feet long, and it's sitting around. When the small bowel slows, though, that allows bacteria that are usually washed out of there into the colon where they belong to creep up in there. And if they get pretty high up in there, then what happens is the bacteria compete with you for your nutrients. So let's say you ate some rice, and that rice gets in your small bowel. The small bowel absorbs rice really well. White rice sucks it all up. Nothing makes it to the colon. But if, on the other hand, there's bacteria halfway up your small bowel, they're going to see that food. They're going to see that carbohydrate, and they're going to start fermenting it instead of you absorbing it. So now they're fighting with you for your nutrients. And what happens is you may take 2,000 calories in a day, but if 500 of those go to feeding the bacteria that are growing in your small bowel, then you're losing that caloric intake and you lose weight and may become malnourished because of that. So again, we're usually, we do a fair amount of diagnostic testing for small intestinal bacterial overgrowth. I have a lot of patients on cyclodent. Here I am going back on my thing. The one area where I will use antibiotics, though, is I have to kind of use it in small intestinal bacterial overgrowth. I don't have much choice there. There's just no way to get those guys out. We try using drugs like prucalopride to increase motility, but just not doing the job. So we have to use sort of cycled antibiotics so that you don't get resistance. So you get a week of one antibiotic, and then the next month a week of another, to keep things going. And patients will gain weight, nutritional status will improve, nutritional deficiencies such as folic acid, B12, et cetera, will improve in those settings. So it's an important diagnosis to make. Difficult one to make. The tests for it are not easy to do and tough to interpret. You'll see a lot of arguments about hydrogen breath testing. I still do it. Sometimes it undercalls things, sometimes it overcalls things, but it's a reasonable starting point. a simple blood test called folic acid is really intriguing. Usually if a patient is malnourished from a malignancy or from pancreatic insufficiency or something, the folic acid level will be low. But in space with small intestinal bacterial overgrowth, because your bacteria make folic acid, your folic acid level will be unnaturally high. So if somebody's not taking a folic acid supplement and they have a very high folic acid level out of the blue, that usually is a sort of a cheap way of figuring out that someone has bacterial overgrowth. So if you're getting labs drawn, you want to know about SIBO. Not that having a normal one means you don't have it, but if it's really high, there's only really one thing that'll do that. And that's because your bacteria in your small bowel will make folic acid for you, one of the little side benefits of having them in there, and you'll absorb all that and you'll have a very high level. In secondary to slow motility, as I mentioned, that peristalsis is really what keeps your small bowel nice and clean and fairly sterile, and you lose that, and they get involved in setting up colonization in your small bowel. They block your nutrient absorption. They can actually sometimes damage the bowel wall, and they cause B12 deficiency. And they manifest as diarrhea, bloating, weight loss, abdominal pain. Pretty common stuff in our scleroderma patients. There's sort of a graphic of what I mean. So you can see on the top line there, there's very little bacteria in the low end of the small bowel. It's mostly in the colon, and the food is getting all absorbed before it even reaches the bacteria in the colon. But you can see when that green sort of splotch moves up the bowel wall, that's colonization bacteria. Now they're going to interact early with these starches and carbohydrates you eat. They're going to create gas, leading to bloating. They're going to interfere with your absorption of those nutrients because they're going to use them first for their own metabolic needs, and you get in a little bit of trouble. Intestinal dysmotility can present with all these pictures. So basically, if this one back here, by the way, that's intestinal pneumatosis intestinalis cystoides. You can see those sort of blebs in the wall of the bowel there. The picture on the far right shows chronic intestinal pseudoobstruction with those sort of donut-shaped sort of, let me come over there. Yeah, so you can see that dilated bowel there on the wall. That's small bowel. That looks, in most x-rays, that's what the colon looks like. But there, that happens to be that patient's small bowel is massively dilated with air. Here's a colonic pseudoobstruction. All that black dark area in the top of the x-ray is air. And that's way too much air to have in your colon. So that colon's not moving and emptying well. So that's a colonic pseudoobstruction. The motility can get so poor that basically the bowel becomes obstructive in nature. There's no physical obstruction, but the motility is so awful that you end up with poor gut flow. And that can be so severe that you end up with nausea, vomiting as your GI tract tries to relieve itself with the pressure built up inside of it. Colonic involvement in about 20 to 50% of patients with systemic sclerosis. The colon doesn't move well. There's a loss of motility and contractions. Constipation would be the main issue there. Colonic pseudoobstructions, which I mentioned, otherwise known as Ogilvie syndrome, where the colon just stops and causes a bowel obstruction for that reason. Telangiectasias or angiectasias are those little blood vessels I mentioned. They're quite common in the colon and probably in scleroderma patients the leading cause of lower gastrointestinal tract bleeding. So we often go in there, particularly on the right side of the colon, find these little splotchy red blood vessels, which are pretty easy to treat. Telangiectasias are my misery when they're in the small bowel, because the small bowel is 22 to 25 feet long. It is not an easy area to get to with an endoscope. We can get there, it's just a very difficult procedure. Pretty easy to get to the colon, super easy to get to the esophagus and stomach. Small bowel, we have to use these things called deep endoscopes to get in there. It takes hours to work our way through the small bowel. And if these little blood vessels are bleeding in there, it's very difficult to get a hold of those guys and get them cauterized. We more often, when we're looking for a small bowel source, do something called video capsule endoscopy, which some of you may have had if you've had GI tract bleeding and they can't find the source through standard endoscopy. We'll have you swallow a little television camera. It takes 7 pictures per second as it toodles its way through your GI tract. And then it sends all those to a little hard drive that you wear on your belt, radio telemetry. And those images then come back, get downloaded to the computer, and we create a basically 7-hour movie of your small bowel. Not the greatest thing to watch in that. Drink a lot of coffee to stay awake for that one. But, so yeah, we do a fair amount of those. It's a great way of looking at the small bowel. It's an amazing bit of technology. And artificial intelligence is getting more involved in helping us read those because they are somewhat difficult to read. But they do help in finding these little blood vessels. And the nice thing about the video capsule study, the reason you want that before you let anybody do deep enteroscopy is they can pinpoint the spot. There's no sense in going from a below with an endoscope because so to get to your own small bowel, we can't do it all this way. So we have to come back from the back end too, what's called antegrade and retrograde enteroscopy. Sometimes we have to go down this way and go as far as we can into the jejunum. Then we have to go back this way and go far up as we can into the ileum. If I can pinpoint with my capsule for the endoscopist this site, is it up in the upper small bowel, lower small bowel, then we don't have to do both of those studies. So that's the importance of a video capsule before you let anybody explore your entire small bowel. Anorectal dysfunction in probably 50 to 70% of patients, usually either inability to defecate with what's called obstructed defecation or fecal incontinence. Of the two, the latter is probably the one that is most significantly affects the quality of life of my scleroderma patients. It isolates you. You can't, you don't feel comfortable getting an airplane on a long ride or going to a movie theater or going out to dinner. So we spend a lot of time and effort trying to fix fecal incontinence and urgency. It's due to scarring in the anal sphincter. Here's our muscle again. It gets scarred and won't either stays too contracted or more importantly stays too open. Can present with fecal impaction and outlet obstructions, but again, more often fecal urgency and leakage and a sense of rectal fullness. So I spend a fair amount of time with my 3 people in this group. It's me, it's my physical therapist who helps a lot with this. Pelvic floor physical therapy is very good at strengthening the pelvic floor muscles in the anal canal. And then if all else fails, off to my colorectal surgeon. There's these injections we can use called Celesta to buff up the sphincter, make it tougher. There's a sacral nerve stimulator to help get things tightened up again. So we work heavily on that. Liver, not much good, well, good news there is not much of it. Primary sclerosing cholangitis is a scarring process of the bile ducts. It says 2 to 20% in the studies I can see. It's more like 2%. It's really rare. I don't have a single patient with that right now. So that's good news. Rarely do they need liver transplant. Usually we're in there trying to open up strictures with my interventional GI guys. It's treated with a drug called Actigol, which is ursodeoxycholic acid. Urso for bear, right? Deoxycholic acid. It's bear bile acid. So why do we want to give you bile acid that looks like what bears make? Because bears don't get gallstones. Bears, for whatever reason, they make this particular bile salt, and it's very non-damaging to the bile ducts in the liver. So it's a very nice, friendly bile salt. So what we do when we give you ursodeoxycholic acid is we shift the kind of human bile salts we make that are damaging in some of these situations, like primary sclerosing cholangitis, to that bears make that is not damaging and is safer. So that's where urso came from. You gotta love some of the stuff they do research-wise. So on to diagnostic testing. This is a lengthy little slide here, but what I want to point out is that motility disorders are big time. So I do a lot of functional testing. So we do esophageal motility testing, which actually, I think it's about 20-25% of patients with scleroderma present with esophageal problems first, and we discover it during a motility study. They have refractory acid reflux, and we drop a motility catheter because the endoscopy looks okay, and lo and behold, the lower esophagus isn't working and the valve is too loose. So esophageal motility testing is very important. The cool thing about esophageal motility testing now is we have a device called FLIP. It's an intraluminal way of doing a motility study. So we have you asleep, we do our endoscopy, we look around, we don't see any problems. During that procedure, rather than have you come back later to do an in-office motility study with a catheter down your nose that can be a little uncomfortable, we have a FLIP device, and it's a little balloon probe we stick in there, and we can blow it up, and we can actually see the motility of your esophagus during the endoscopic procedure. We can measure the compliance or the strength or the weakness of the valve. We can look at what are called secondary peristaltic waves. So primary peristaltic waves occur when you swallow. So you go out here and have lunch today, you swallow, boom, it gets pushed right on through, top to bottom. Secondary is where there's something in the esophagus senses a pressure and distension, and it clears things from, let's say, the middle of the esophagus down. So we can't have you swallow when I got you asleep for the endoscopy, but I can tickle your esophagus a little bit by stretching it with a balloon and making it contract to try to clear that balloon, and we can see these nice contractions on the screens. So it's really cool because, again, it spares you a second invasive procedure. The data is very robust. It's very comparable. It does help, work through the diagnosis of scleroderma. We can figure out how tight or how lax your valve is. If you're having a lot of trouble with reflux, we can figure out whether the surgeon needs to help out with us. So it's a really nifty test. Rhonda Abraham does it at our institution. I'm learning how to do it. But it's a very nice study. The other one we do is called impedance testing. So impedance testing lets us look at both gas and liquid flow in the esophagus, up and down. So we can look for regurgitation episodes. We can look, is this air moving up in the esophagus causing the chest pain, or is it fluid moving up? Let's say we've got great control of your acid. There's no acid in the esophagus when we measure it by an acid probe, but you're still having miserable trouble with regurgitation and such. We'll do an impedance study. We'll see if there's flow. So if there's flow, but there's no acid in it, but that flow is causing you symptoms, then a surgical repair of the valve may be necessary to control that symptom. Esophageal pH monitoring, if you're still having acid heartburn and we've given you twice daily proton pump inhibitor therapy, we're not getting traction, we may take you off of that. Put a pH probe, a little button that goes in your esophagus and measures acid for 4 days while you wear a little box. The information on the acid level in your esophagus is sent to the box. The box has buttons you push. Tell me what's going on. Are you coughing? Do you have sore throat? Do you have heartburn? We bring it back, dump it in the computer. The computer shows us how much acid's in your esophagus. When that acid's in your esophagus, does it correlate with your symptoms? If it does, and we're not getting good control with medications, then you might be a good surgical candidate. Wireless, let's see, then endoscopy. Endoscopy is mostly, again, just for looking at mucosal damage, checking you for Barrett's esophagus, and then endoscopic control of things like Barrett's by removing it with a Barrett's probe, and then our capsule endoscopes. But most of what we do is our motility studies. We don't do much motility studies in the colon or small bowel. They're tough to do. There is a device, there is a wireless motility capsule device that, as far as I know, still has FDA approval. What it doesn't get is a lot of insurance company approval, so we haven't been able to do that study lately, unfortunately. So treatment options real quick here. Lifestyle modifications, sleep at 30 degrees, sleep on your left side, and don't eat within 3 hours going to bed. Nothing else matters too much with regard to lifestyle modifications. If you're taking a proton pump inhibitor, you kind of eat what you want. I always use this phrase with my patient. Mark Twain once said, eat what you want, let the food fight it out inside. That's sort of my theory. You guys are 10 times better than I am at telling me what you can and cannot tolerate. You know, one woman's poison is another's dessert. I can't make quite heads or tails of it. So you tell me what you don't tolerate, stay away from that. But from the standpoint of what you can really do, again, is avoiding eating within 3 hours going to bed, sleep on that left side, or at about 30 degrees if your spouse can tolerate sleeping in bed at a 30-degree angle. Acid suppression stops acid production. Proton pump inhibitors are vastly better than H2 blockers. The problem with Pepcid and Tagamet and dearly departed ranitidine is that they conk out over time. You develop a resistance to them over time. That never happens with proton pump inhibitors. You will not lose efficacy with proton pump inhibitors. If they work for you today, they'll work for you down the road. If they stop working, something else is going on. It's not an issue with your acid production. Your body cannot work its way around proton pump inhibitor suppression, but it can work its way around H2 blockers. So one of the things I've seen primary care docs doing is going, I don't want you on the proton pump inhibitor, so let's go down to Pepcid. Well, that's fine for about a month or two, and then the acid reflux starts coming back. And so again, it's not ideal for patients who have very high risk of acid exposure and a lot of risk of damage from acid exposure. Not a good drug in a scleroderma patient. Prokinetics, again, Reglan, not my favorite. But I'm interested in the data on procalcipride, which is Motegrity. As I mentioned, that's a total gut prokinetic. Does seem to help the esophagus clear, does seem to help the stomach clear, definitely helps the colon clear, may help with the small bowel motility. So if you are having trouble with both heartburn and constipation, you want a drug that might help both ends of that spectrum, literally, see if you can get Motegrity or procalcipride approved. You may have to jump some hoops with the insurance company, like try Miralax or try lactulose, God forbid, first. And if you fail that, which with lactulose you probably will, then you can move on to something like procalcipride. I'll make my little editorial about lactulose. I know it's a favorite of a lot of primary care docs. I much prefer Miralax, which is polyethylene glycol. Problem with lactulose, it's a non-absorbable carbohydrate. And the last thing I need for my scleroderma patients is to get a non-absorbable carbohydrate which is metabolized and fermented by bacteria. They already have a lot of trouble with bloating and bacterial overgrowth. They don't need non-absorbable carbohydrates. So I don't like that drug, particularly in scleroderma patients. A lot of bloating, a lot of discomfort, not all that great for constipation. If you want to use that early type of laxative, then go with Miralax or polyethylene glycol, and then move quickly into the prescription medications like procalcipride. I mean, I would really push procalcipride over the other constipation meds like linaclotide or Linzess. You've seen that advertised a bunch. Trulance, Isbrella is another new one that came out because of its ability to move the gut top to bottom, which makes it unique for scleroderma patients. I like that one. Low mag levels, very rare. Again, we talked about the proton pump inhibitor. Check those yearly. Kidney problems, very rare. Check what's called the BUN and creatinine yearly. Probably if you're seeing the doctor, you're getting that done automatically. B12 deficiency, pretty rare. The evidence is sketchy, but if over the age of 65, if you're on Nexium or Prilosec or something, you want to check that once a year, I have no problem with that. There does seem to be a slight increased risk of COVID infection when they looked at this. The data is a little sketchy, but be sure to keep up with your vaccinations there. Other issues, all this stuff has not been proven. So I put this up here because you're going to hear about it. If you're searching the internet, there's going to be a lot of axes to grind against proton pump inhibitors. You may hear it from your primary care physician. I don't have any data that any of this is true. There's suggestions of it, there's associations, but there's been no cause and effect analysis to suggest any of these things are true. So you have to be able to be careful, particularly with scleroderma, because your risk-benefit ratio really favors good acid control. And these just don't hold a lot of water quite yet. Unproven. Novel treatments. So this is kind of cool. First off, endoscopic treatment of reflux disease. We have some nifty treatments there to try and tighten up the valve endoscopically without surgery, which is kind of neat. So something called TIF. There's a new class of drugs should be out this year that is significantly easier and more potent than the standard proton pump inhibitor. They're called PCABs, or potassium competitive acid blockers. They'll probably be, from what I can tell from the meetings this week, they'll probably be coming out in the fourth quarter this year. Vonazepam is the name of the one drug. It's pretty amazing. What's nice about it compared to your friendly Nexium Prilosec is you take whatever you want. It will suppress pumps, acid pumps, whether they're active or not, which is pretty cool. So it's a very potent drug, allows a lot of leeway with when you want to take it. It will work in some patients who have failed traditional proton pump inhibitors. Doesn't seem to have any particular excess risks or side effects. So these are called PCABs, PCABs. They will be out in December, and they will probably take the place of the traditional proton pump inhibitor in the management of scleroderma-induced disease because of their extra potency with no additional side effects. There are some medications that help with sphincter relaxations. These are all strictly in the research category right now. GABA B receptor drugs, cannabinoid receptor 1 drugs, CCK receptor antagonists, all seem to be where they're trying to get drugs that will really tighten that valve for you. And so those three are in clinical trials but are not quite ready for prime time. But keep your eye out for those. I think in another 2 or 3 years we may have drugs to tighten that up. And might run out of time, by the way. Yeah, 10-15. Okay, real fast here. Surgery. We almost never do Nissen fundoplications where they wrap the whole esophagus. We're pretty much sticking with the toupee procedure, where instead of, if we need to tighten the valve at the bottom of your esophagus, rather than wrapping at 360, we'll wrap it about 270 to 180 because we don't want to overwhelm that sort of weakened esophagus. So I probably send one patient a year for that procedure, not with the proton pump inhibitors, usually I can control the reflux. Stomach treatments, again, metoclopramide, domperidone to increase motility, compazine, Tygan, Zofran for nausea, vomiting. I do botulism injections into the pyloric sphincter valve when the stomach won't empty to weaken it and to let it open better. So we have, the success with that's variable, but the new one on the box is at the bottom there, POEM. So that stands for per-oral endoscopic myotomy. So my interventional guys will go down and they'll open up the valve at the bottom of a stomach that won't empty properly, endoscopically cut into the muscle and get it opened up so that it empties a little more easily, which is really cool. So that takes it's about an hour procedure, no surgery, no cutting, all just endoscopic. So we've been doing that a lot for refractory gastroparesis lately rather than Botox. Intestinal treatments, diet, low FODMAP diet, you've probably heard about that. I would strongly encourage that for my scleroderma patients. Low FODMAP's a great way to go. It reduces the fermentation of the gut, but do it with a dietitian. You need some FODMAPs in your diet. They're healthy. You don't want to take them all out, but you want to find the ones that cause the most gas generation and fermentation in you, and a dietitian will help you work through a specific protocol to figure that out. So those are great. As I mentioned, much as I hate antibiotics, I do use them a lot in my scleroderma patients who have documented bacterial overgrowth through breath testing. What we'll do is start you on one like Xifaxan for a week, then the next month will be doxycycline or tetracycline, the next week will be metronidazole, next week might be Augmentin if you're not pen allergic. And we cycle those, so you only see them 3 times a year. And that is effective in improving your weight, improving your nutritional status, reducing bloating and diarrhea. So you got to rotate them. You can't just hit once and then come back. FODMAP, I'm going to move on quickly here, but if you go online, you'll see a lot of stuff on FODMAP. But I will tell you the best app if you want to get it, the University of Monash, University of Monash. That's Dr. Peter Gibson. He's the guy that invented this diet. He has an app. It's like $6 at the app stores for both Apple and Android. Great app. Lots of data on how you do a FODMAP diet, why it makes sense. Has a nice food diary in it. I'd still do with the dietitian's advice, but that app is really worth the price of admission. So let's zip past here. I'm not going to spend too much time on colonic pacing. Anorectal treatments, so really quickly, Lomotil, Imodium for mild versions of fecal incontinence. Tricyclic antidepressants, for some strange reason, reduce the sensitivity of the rectum, so they can be helpful in urgency. Really important pelvic floor physical therapy. Surgery, usually injectable silicone called Celesta is helpful. And rectal prolapse repair, and then sacral nerve stimulators. New treatments, I mentioned procalipride. That is being used actually again to improve gut motility throughout. Busprone is being investigated to tighten the lower esophageal sphincter valve. If you have refractory regurgitation and you're on your twice daily proton pump inhibitor, that may be a drug to help you out. It's available now. The PCABs, as I mentioned, will be out later this year. I probably will shift a lot of my patients from standard PPIs to PCABs this year. And then probiotics for bloating, plus minus, I mentioned, be a little bit careful about those. And then, as I mentioned, the rotating antibiotics for small intestinal bacterial overgrowth. And I will shut up there, so thank you.